I think that the capsule can continue to serve as a nidus of inflammation, if you will, if you leave it behind. The reason I think that's because I've seen patients like that. I've seen a small number of patients who just had their implants removed by other doctors with the capsules left behind, who did have significant improvement in their symptoms. Maybe it didn't completely resolve, but they had fairly significant improvement, but still wanted their capsules out, and then I'd go back to other capsules down the road, and they would feel even better.
Hey friends, welcome back. This is the Ancient Health Podcast. We have an incredible guest with us today, hailing all the way from Beverly Hills. We have Dr. Kevin Brenner. He is a nationally renowned plastic surgeon, board-certified plastic surgeon, but he has really made a name for himself, especially advocating for his patients, which are predominantly female, I imagine. So I'm really excited to get his take because we have a lot of voices. We have a lot of opinions in the space of plastic surgery, but getting it from the surgeon, from the doctor that's actually working on these patients, I think is going to give us a different perspective. So Dr. Kevin Brenner, welcome to the show. So glad to have you. Dr. Chris Motley, thanks for joining us always.
Thank you. Nice to be here. Nice to chat with you guys.
Oh, it's a pleasure, Doc. And we really want to get down to having the expert opinion on this because I know that Courtney's had her personal experience and her personal journey through this. And we really like for the individual, like the doc who's the expert, to like run with it and give us their ideas and their expertise on this. So and I think it's something that's really affected a lot of people and individuals out there. So again, thank you so much for joining us.
My pleasure.
I would love to ask you, I imagine that being a plastic surgeon, you going to school, going to medical school, you probably never thought you'd be doing explants or even like having that many conversations with women about that because of the, really not understanding maybe the long-term health effects or implications of it. What has been your experience for women? Kind of when was it that the bell kind of went off and you were like, these might be causing a problem and we need to maybe take a closer look at it? Because I mean, there's obviously kind of been like a major shift around the conversation of BII.
Right. Well, for starters, because that was a very complex, compound question. For starters, I actually went to medical school to become a pediatrician, not to become a plastic surgeon.
What? Really?
That's what I thought I was going to do. I swear. And it was somewhere during my clinical rotations where I was like, pediatrics is not for me. And I love surgery, and I particularly love plastic surgery because of the creativity.
Oh, yeah.
So that was that. And then once I decided to do that, which was still a long road because I did residency first in general surgery and then in plastic and reconstructive surgery. Well, once I did that, I've always kept sort of a very broad-based practice in terms of things that I do. And there, I didn't pigeonhole early, like some people do in their career, like one thing or the other. So, but I always had a very breast surgery heavy practice just because of my background in breast surgery as a general surgeon. And it always interested me. And very quickly in my practice, I became sort of new for handling breast implant complications, revision cases, if you will, which then for many years was doing what I call aesthetic reconstruction. So that is, as opposed to like cancer reconstruction, this is really patients who had implants for aesthetic reasons who developed capsular contracture or a malposition where the implants in the wrong place were just a bad result, and trying to revise them and make them look normal again. So that's sort of where I started. And then years ago, I saw maybe one or two patients that came in claiming that their implants were making them sick. And at that time, to be perfectly honest, I didn't really think much of it other than if patients can come in and ask me to put in implants, why shouldn't they be able to ask me to take them out? I didn't know at the time whether it was going to move the needle, whether they were going to get better, but lo and behold, I take them out and the couple patients did better, and then, one patient became 2, became 10, became 100, now hundreds and hundreds and hundreds of patients. And it was about maybe 6 or 7 years ago when I started to notice a huge increase in patients coming in, saying that their implants were making them sick. And it was probably about 5 or 6 years ago when the term BII actually came to be. And so as I've focused on that, and as I've been taking care of more and more patients, more and more patients get referred in. I'm now pretty well known for doing this, even though I do lots of other things in my practice. It's not narrowly focused only on explant surgery. I mean, I still do facial surgery, noses, and liposuction, and all sorts of different things, and reconstruction, skin cancer reconstruction. But this is now a huge portion of my practice.
With the breast implant illness, Doc, many people out there are going to ask, like, what are the basics? Like, why would somebody get sick from a breast implant? Because some people that are listening to it, they're like, and I had one of my good buddies in Austin, Texas, his girlfriend, she was sick completely, like, from the first time he met her. And so he was getting a bit frustrated by trying to, like, he's a physician, he was trying to take care of her. And she found out she had breast implants, and there was a practitioner in Austin that did the explant, and then she really recovered like 80%. But at the time when I first heard about this, what is it about the breast implant that makes people sick, or what is the whole process that makes it sick to the body?
Well, that's the magic question. That's what, all of us who are interested in this are trying to figure out. And it's also what I don't really have an answer for it, because we don't know 100%. What I think it is an immunologic response to having a foreign body implant. I mean, everyone who has a breast implant has an immunologic response to it, because your body's immune system says, hey, this is foreign. Even if it's sterile, right? I mean, there's no bacteria or viruses on it. It's still a foreign. And it doesn't really, to be perfectly honest, it doesn't really matter what the material is. If it doesn't naturally exist in your body's going to recognize it as foreign. So your body actually tries to wall off the implant and creates a specialized part of scar tissue called a capsule. And so every single person who has breast implants needs a capsule around their implant. Most of the time, it's a nice, normal appearing, thin and soft capsule. They're so thin, oftentimes you can read a newspaper through them. And most women will tend to live in harmony with the implant with a normal capsule. And most patients with breast implants, even though they have a capsule, are doing just fine. But there's a subset of women, and a growing subset of women, who don't do well. And that, whether that's a month, a year, or 10, 15, 20 years after they had their implants, I'm now seeing it. And I think part of the problem before, had we been having this conversation 10 years ago, it would be very different, because 10 years ago, I probably never really asked patients how they were feeling. It was really like, how are you looking? Like, is everything okay? Are you having any physical, demonstrable problems with your implants? Is it hard? Is it in the wrong place? Are they symmetric? Those are the kinds of things that we and then, quite honestly, what probably most plastic surgeons are looking at and thinking, hey, it's okay, are the breasts symmetric, everything okay, see you in a year. And it wasn't until I started asking patients, like, how are you feeling? And then very specifically getting into, because I have a questionnaire now that everyone fills out in my office, like, do you have joint pain, and how severe is it? Do you have hair loss? Are you having brain fog? Do you have nerve sensation in your hands and feet? There's 40 to 50 different symptoms, and even today, as recent as last week, sometimes when you ask patients to fill this out, they still don't think that there's anything wrong, or they still don't think that there's a correlation. And maybe there is, and maybe there isn't. I mean, the biggest problem with breast implant illness is that the symptomatology overlaps with so many other disease processes. And if you have this sort of spectrum of different symptoms, if you just pick one thing out, for instance, chest pain, right? Lots of things can cause chest pain. It could be from your heart. Do you have coronary? Do you have an arrhythmia? Do you have could you have bruised your rib? Is there something wrong with your lung? All these different things can cause chest pain, and some of those are more serious than others, and some need to be ruled out, and that goes pretty much for every presenting symptom. Maybe some people present with a lot of people present with like autoimmune phenomena like Hashimoto's thyroiditis. Well, people without breast implants get Hashimoto's. The question is, did the implants cause Hashimoto's? Did maybe they had a predisposition for Hashimoto's, and the implants are allowing the immune system to sort of exacerbate the symptoms of the Hashimoto's? I don't know the answer to that, because you could ask that for every single symptom that patients walk in.
Yeah, I mean, it makes sense too. I mean, it is complex, so I think that you can't ever take any one thing off the table. I think that one of the differences now, like just in this day and age, is that our endocrine system is so overloaded. Like, we're so toxic. There's so many different toxic threats to our bodies, and our immune systems are already like teetering on the verge of being very dysregulated. Like, it's not like it's calibrated the right way. So it's not responding in a way that is favorable. And so women are just experiencing wild symptoms. And, I think a lot of things are already existing to some degree. And then you add the implants, and it's like the straw that broke the camel's back. And it's like the wheels fall off and everything just goes to hell in a handbasket. So,
right. It's like you have an analogy I like to use. It's like, the U.S. has one army. If you have 1,000 soldiers and they're all fighting on one front, and then you get attacked on the other front, you have nothing left to fight.
That's totally.
And it's kind of similar. It's kind of similar to our immune system, in terms of, I think that maybe some people have some subclinical thyroiditis, right? Maybe you have some inflammation of your thyroid, but like your thyroid levels are normal and you're not experiencing something. And then you have an insult like a breast implant, right, where your immune system's now constantly like trying to wall this off. And by the way, this doesn't just happen with breast implants. It does happen with like some types of hernia mesh, for example. You have that, and then like you suddenly different symptoms are kind of start creeping up because your immune system doesn't have capacity to rev up and amp up. And a lot of this has to do with your endocrine system, which you mentioned. And in fact, I just had this conversation recently. I have a podcast myself. I have one of my breast team members, Dr. Nikki, she's a naturopath, and we had this whole discussion about a term called adrenal fatigue. Now, adrenal fatigue is if you are in naturopathic medicine, which I'm not, but I know enough about it now. It's a term that a lot of people use. A lot of people probably misuse. It's very different. It's not adrenal gland failure, but it's just your adrenal gland just sort of poops out. It's like the engine can't go to capacity anymore. It's still going, but it's just you can't rev to 4,000 RPMs. And then, what most patients don't realize is that your endocrine system kind of all interrelates. It's not that you just have your thyroid axis and then your sex hormone axis and your adrenal axis. They all kind of interrelate. So if your body's not able to produce cortisol, which is one of the main things that your adrenal gland produces, that has an effect on your thyroid gland. That has an effect on your FSH and your LH. And therefore your estrogen and progesterone and testosterone production in men and women. and they all kind of interplay. And it's not entirely shocking that patients present then with this increasingly severe fatigue to the point where some patients are really sidelocked with fatigue. Like they can't take care of their kids, they're not present for their spouse. Some of them can't go to work because they just can't muster the energy that all of us kind of muster every morning. We get out of bed and do the things that we do.
Well, it's saying, Doc, when you I think that's really important, because when you say they can't get out of bed, they can't, be with their family. When an individual comes in, and are those like the telltale signs? Like when somebody, even if you hear from the grapevine, like you have a patient that wants to come in to see you, and they are prone to have this, that you say they may have a breast implant illness. So that was something on your questionnaire that people say, like, I'm totally tired, I'm totally fatigued. Do you also look at like their lab reports and tell them like, we need to run a lab on you? Or is it something you suggest to them to go do that gives you an indication that they may have issues with their breast implant illness?
That's a great question. I actually see both ends of the spectrum, but at this point in my career, to be perfectly honest, most patients that come in have already kind of gone down the rabbit hole.
Yeah.
Most patients have been to their primary care doc, whether that be their oncologist or their internist or the family practitioner, and had, whatever worked up, whatever symptoms worked up. And then usually for some of the more kind of serious things, those get farmed down to special, like cardiology, rheumatology, neurology, gastroenterology. Like these are, all the patients come in, they're like, oh, I've been to 10 doctors already. And all my lab tests are normal. No one can figure out what's going on. And they're just, not only are they not feeling well, but they're frustrated. They've also usually put forth a great amount of time, energy, and money to do that. I've been a patient, and I know what it takes to try to coordinate one doctor's appointment into your schedule, let alone going to 10 different doctors on multiple occasions. It becomes a career for some people. I've had patients come in with their husband with a stack of consult notes from different people. I even had one patient that I distinctly remember who came in with her husband, and he had 2 stacks because they had originally been in the Kaiser system, got no answers there, finally got some real insurance, and then did it in the private world, and still had no answer. And lo and behold, that was her implants. So we took them out, and she did better. And listen, I don't try to upsell this at all, because if there's no guarantee that taking someone's implants and taking another capsule is going to make them better, or is going to even improve their symptoms at all. But about 80 to 90% of patients do have some improvement in some degree. And, 80 to 90% rather is pretty good. And now, does that mean that there are some patients that don't feel better or don't feel appreciably better? Yes. But that doesn't mean that we need to stop taking care of the ones that do. So the big question for us, and the kind of focus of where I think our research needs to be, is how do you figure out who those patients are? How do you figure out who is predestined to develop systemic illness with an implant? And then the next question is if you do develop it, who's going to do better? Who's gonna have improvement in their symptoms if you take it out? Now, I don't know how we're gonna figure that out, but we're trying.
Yeah, I think understanding individual health, people really that kind of like N of one, and really knowing the bio individual is the only way. Just because there's so many factors, but I think that most of us are not that educated. A lot of people that are listening to your podcast and our podcast and other, really trying to access resources are trying to put the pieces together, but it's really not a part of our culture for people to understand how their bodies work. Like, other than maybe like biology, I feel like that's a total miss.
Well, that's a whole nother conversation.
It totally is. I'm not trying to open that can of worms.
Oh, great. Oh,
Our
good.
education system is definitely superior in this country. There's no question. But and first of all, that's why I spend so much time with patients when they come in, because part of my job is to educate them. Even though most of my patients are quite well read by the time they come in, I don't know if what they've read is the right things, and so I just treat everyone kind of the same. Start from square one. Here's the explanation of what I think is going on. Here's this breast implant illness. This is what we can do. This is what yes, I think surgery is going to help you. No, I don't think surgery is going to help you. And kind of going through step by step. Here are the logistics, etc. And so a lot of the consult time is just that. It's education, which is what it should be. Right? That's why people come to me, because for this specific thing, because I know a lot about it. I just lost my train of thought.
No, you're totally good.
But yeah, what I tell people and what I think often gets recognized, gets overlooked rather, is that you really should trust your intuition. And I've seen it so many times over and over again. No. Trust your intuition, and saying that all doctors and medicine are bad are two separate things.
Mm-hmm.
There are outliers in any profession. There are doctors who are terrible and don't know what they're doing. There are surgeons who are terrible and don't know what they're doing. And that goes for lawyers, and that goes for business people, and that goes for everyone. As a rule, I like to give people the benefit of the doubt, and I think you should, in general, trust your physician. If usually people know when you talk to someone, if you think that someone's trustworthy. Usually you trust your physician, and I still think you should trust your physician, trust that they have your best interest in mind. But just because they have your best interest in mind doesn't necessarily translate to them knowing what the problem is or how to fix it, if it's fixable. And the other thing is that I hear, and this is only because I hear it from so many people who get sort of brushed off by their physician, whether it's their primary care physician or their plastic surgeon or other surgeons. They just are told that there's nothing wrong with them. It's in their head. Some people are told that they're crazy. And yet I know, like I can usually sense it now after reading through paperwork and interviewing with patients. And it's when someone is really not feeling well. And usually they know that something's wrong. Like if you know that something's wrong, most people know what something's wrong with them. And so it's super important that if you really think that something is wrong, if something doesn't seem quite right, to be persistent about it. And if you're not getting the answers from doctor number one, then you should be going to doctor number two. And if you're not getting it from doctor number two, you should get it from doctor number three. And even though that can be costly in terms of time and money and energy, it's at what cost? It's what's most important to you, spending that time or getting your help.
Yeah, I mean, because Doc, I can tell that you're really, like, when you say that you can talk to somebody, and you can tell, right when you talk to them, because I can tell, like in Chinese medicine, they always say you can have the demeanor of like being intuitive about things, where you go, I have an idea when you're talking to somebody. You can tell when you talk to you. So when you're expressing yourself. So let's say somebody comes in and you know that they could have a problem with the, breast implant illness. When because you talked about your creative side, you like to be creative, and you start to see these like small signs and signals. Is there any indications, like when a patient comes in, yes, they could have breast implant illness, but they could have like a predisposition to have, like, they had an old infection, they had old things that could cause a sickness to like abound in their body? Do you ever you think, okay, something's going on, I know this could be an issue, I need to refer them or test them for certain types of infection? Because many people will say, like, I feel like I have the flu, I feel like I got my strep throat. Do you find any type of infections too with your intuitive, like when you're talking to people? Do you ever see anything like that?
Well, yes, but it's not as common as you may think. probably, there is some thought in terms of breast implants, since it's a sterile implant, right, in your body. There are entities that can cause infections of breast implants, although a true overt infection of a breast implant is fairly rare. It usually only happens in the setting of, someone just had surgery and they're just not taking proper care of themselves and not being cautious enough, and the incision opens up. Or if it's, let's say, like a breast cancer reconstruction patient who has radiation, so their tissue's not quite as healthy, their immune system's not quite as healthy as someone, and they have an implant-based reconstruction, they may be more prone to, like, let's say, a bacterial infection. But there are other infections that can happen. Number one, I touched on it briefly, but capsular contracture, which is an exaggerated scar response of the capsule that exists around the implant, that we know that there's a bacterial etiology, right? We know that in a very high percentage of those cases, there are types of bacteria that can get into that space in between the implant and the capsule and not cause an overt infection like you would think of an overt infection like a tonsillitis or appendicitis or an abscess, pimple, what have you, but just cause what's called a slime layer, which then stimulates the capsule to tighten down. So we know that there's a bacterial cause for that, and there are some surgeons who've studied this and actually done, as it relates to breast implant illness, have done actually swabs and sampled the capsule for various bacteria. Now, I years ago was also doing that, but I got a very low yield, and maybe it's because I'm in private practice and I don't have a microbiology lab at my beck and call. I mean, I can send stuff out, but it's not quite as efficient as if you're like at a university where it's there. I got a really low yield. I know a surgeon who got a very high yield, and who thinks that 80% of patients who have BII have some sort of, not infection, but colonization with bacteria. So that's one thing that, like infection of the device itself. I think what you're referring to maybe is systemic infection. And with that, we think of things like Epstein-Barr virus, Lyme disease, things like kind of lay dormant in your body you may not know, but have very kind of presentations. And some of them have very similar presentations to some of the symptom BII. So that's why I think there, a lot of the naysayers, if you will say, well, maybe they had, Epstein-Barr virus when they were younger, and this is just a manifestation of mononucleosis. Or are you sure they didn't get Lyme disease and have begun tanning? What part of the country? Let's test them for Lyme disease, which is not easy to test for. Or let's test them for mold. And those things do exist, but they also don't cause all of these symptoms that we see with breast implant illness necessarily. They may cause some of them, but certainly not all.
Do you recommend, or do you do this in practice, that you always remove the capsule when you do an explant?
I do now. Yes, I do now, because there's several indications for removing the capsule. I think BII is one of them, at least for what we know now. Some people don't agree with me. Some surgeons don't agree with me. They're having some studies going both ways, although, to be honest, I think both those studies are a little bit flawed and not very powerful in terms of the statistical analysis of it. But the thought is this: that you have this specialized scar tissue that was formed around a foreign body. I'm not one of those people who thinks that the implant necessarily is dissolving, disintegrating, and eluding its contacts into your bloodstream. Because there are a lot of people that say, breast implants are toxic. We know they're made from arsenic and this chemical and that chemical and silicone and all this stuff, and it can't be good for you. And while that may be true, I that doesn't necessarily translate into, oh, I have this plastic silicone shell in my body and it's disintegrating into my bloodstream and causing these symptoms, like you would think of lead or mercury toxicity, right? Which you can get from environmental exposure, and as those levels build up, can cause neurologic manifestations. That's part of it. I think that the capsule can continue to serve as a nidus of inflammation, if you will, if you leave it behind. The reason I think that's because I've seen patients like that. I also have seen a small number of patients who just had their implants removed by other doctors with the capsules left behind, who did have significant improvement in their symptoms. Maybe it didn't completely resolve, but they had fairly significant improvement, but still wanted their capsules out, and then go back to the other capsules down the road, and they would feel even better. Now, that begs the next question. Well, like, and again, the people who don't believe in this will say, well, it's really kind of more dangerous. It's more risky. There's more complications with taking the breast capsule off than if you leave it in. And so that's why we need to get to the bottom of like whether or not that helps or not. And that is true. And I tell this to every single patient, taking out a breast capsule does confer a slightly higher risk of bleeding postoperatively, sensory nerve injury, scarring to the tissues, in theory, pneumothorax, where you can get into the lung cavity and that can drop down, even though it's exceedingly rare. That these risks all are higher if you're healing up all this tissue and creating this raw cervical space. It doesn't mean that it can't be done safely, and it doesn't mean that it shouldn't be done safely. I do it multiple times a week, and I think if it can be done safely, that I'm sure there are cases where patients had any previous operations and the scar tissue is so bad that it's probably not worth the risk. But for the overwhelming majority of people, that's not the case.
Okay. I mean, have you seen, like, with Doc, if, like, let's say somebody, was wanting to get to remove the capsule, and you say, well, it's not really worth the risk. And people out there may be asking, did you find that if you did leave like some capsular in there and you say, well, the scar tissue's in there, are there like recommendations you give them and you've seen them like thrive, even if you left it in there and you say it's not worth the risk? I mean, they're doing pretty well, like with their health and such. Are there other things they could do to like offset that, like minerals and vitamins or anything of that sort, if the capsule had to be left in or the scar tissue had to be left in the body?
I can't give you a specific answer about that, just because it's way more complex than that. My personal feeling is that if someone's doing fine, for most people, if they're doing fine, they're feeling fine, then they're doing fine, then they're feeling fine. If they're not, then we need to investigate. Did their original surgeon take other capsules? Is there something else? Is it not BII at all? Is there something else going on? So, listen, as that handful of patients where I've taken up capsules, and I'm pretty OCD about it and getting everything out, and they just don't really significantly change after surgery. That does happen in a small fraction of patients. I can't explain why, other than maybe there's some other entity going on. But yeah, I don't think it's as simple as saying, "Oh, we'll go take some glutathione and you're going to be fine." Because I don't know if that's me. Is it going to hurt? Probably not. But is it going to help? I don't know. And then the other issue apart from that is, in terms of did another surgeon lay the capsules in, comes down to kind of the more recent announcement by the FDA and safety announcements of cancers that have shown up. And now this doesn't specifically have anything to do with BII. I'm just explaining in terms of the capsule removal. Cancers that are kind of implant related cancer, not breast cancer, but they're ALCL, which is a anaplastic lymphoma, and squamous cell, which is relatively new as of last fall, newly reported, I should say. These are two different types of cancers that we know have formed around glands in the capsule space. Now, the rate of that happening, the relative risk to any one individual is exceedingly low. I'm not trying to sound an alarm at all, because I'm not an alarmist, but I'm just mentioning it for completion's sake because some people are concerned about that. And in particular for patients who've had certain types of textured surface implants, because back in 2019, the FDA issued a safety warning, and Allergan, one of the implant companies, voluntarily removed all of their biocell textured implants from market, took them off. Didn't recommend removing them for patients that already had them, but took them off so that new more could be implanted. And the reason behind that was the really high association between those specific implants and ALCL. So the FDA had looked at roughly a period of 10 years where they were following cases that had been reported to them. You'll see all the special lymphoma that developed in the capsule around breast implants. 85%, give or take, had some exposure to Allergan's texture. So, there's BII, but BII can happen with saline implants, smooth texture, and I've seen it pretty much with implants from all of the major implant companies in the U.S. And then there's these other much more rare but obviously scarier possibilities of ALCL and squamous cell carcinoma.
Yeah, those are the implants that I had. The Allergan textured. I remember getting a letter in the mail too, and it was like, "Hey, just wanted to let you know, we're."
What did your letter say? I'm curious because I never put in a pair of those in my career because that's a whole nother conversation. But what did they say? What did that letter say? Yeah,
I mean, almost exactly what you paraphrased, which is really just, no need to worry. These are the evidence or studies, have shown that, there is this very, very small percentage that, this specific type of implant, because of the textured nature and just the way that it's manufactured, has been associated with, BIA, ALCL, and, but there's no need to explant unless you have, a proclivity for cancer or, have some type of condition that would be more complex or alarming. But yeah, I did. I even saved it. And I think it's with my implants, which, I still have in a biohazard bag. I don't know if I'm just saving those for like the Smithsonian. They're like an artifact.
So you didn't put them in a shadow box? You used to put them in a shadow box with a letter, like our flag. Yeah.
I know. That's a good idea. Yeah. Well, my husband's like, I've spent so much money on him. I feel like I need to, it's like a giant check just sitting on the wall between the implant, the explant, and everything. It's like, but anyway.
You could turn it into a piece of artwork for your home.
That's true. I would love for the kids to share with all their friends. Yeah, the kids come over and they're like, "What's that on the wall?" We're like, "Oh, those are Mom's boobs." They were.
That's.
I mean, I don't know.
That's a different conversation.
Yeah. Oh, totally. So, our friends here, they know nothing's off the table with me, so it wouldn't surprise them.
Oh, I mean, with that though, like with the amount of like the litigation, Doc, do you find that there are certain, okay, I don't want to like zero out any company. I'm saying, do you find that there are certain types of implants or certain types of material that work better for the body in general? Or like if somebody was thinking, I want to get implants, what would you suggest, like any company or like certain types?
We're not advocating for it.
I'm not advocating. I'm just saying there's going to be people ask that. I mean, there's people that come, Doc, they come to my office, they ask, and I'm like, I don't know anything about that per se.
It's a fair question, and for there was a period of time where I was taking care of breast illness patients where I was still doing like some revision implant cases and still like taking out old ones and putting in new ones. And I finally, last year, stopped doing that, and it just didn't seem right to me anymore. But that's a fair question, and I don't know that I have the exact correct answer for you, but I will say that I've seen. I don't think it's necessarily specific to the implant type. All breast implants, the material in the shell is the same. It's still polymer. Even if the filling is saline versus silicone, that we talked before about, like, indications for taking out the capsule. There are, apart from just being symptomatic for BII, there are situations where capsules are contracted. There are situations where they're completely calcified or replaced with calcium. There are situations that I've had a handful of these where they're like old hematoma that cause like this thick capsule that have been sitting in there for years. And then probably more specific to silicone implants is when you had it. So the big difference between one of the big differences between saline and silicone implants is that if they rupture, right? So if you rupture a silicone implant, for the most part, people get a flat tire. The saline leaks out into your body absorbs it, and you just left primarily just the shell. Silicone implants, on the other hand, especially the newer generation ones, where it's more like a run flat tire, right? So you can get a leak or a tear in the shell, and it still holds its shape because the silicone is really like a firm tofu consistency, and it doesn't just leak all over the place. Now, that's one thing. The other thing is that silicone implants, even when, even the newer generation of silicone implants, even when they're not ruptured, when you can't find a macroscopically identifiable hole in the shell, you can get what's known as silicone gel bleed. And what that is you have this implant, it's at, body temperature 98.6 for X number of years, and the silicone can permeate through the shell into the capsule space and can create what's called a silicone granuloma reaction, which is like this kind of cobblestone appearance that you see on the inner lining of the capsule. When they rupture, that silicone material can actually, even though the capsule's a kind of a closed entity, the silicone material can make its way through the capsule. Yeah, I've seen it in the extracapsular space going into the breast tissue, and can create these kind of like rubbery nodules, which are really scary if you're a woman and you feel like this big nodule outside of your implant. And so, that's when you get that silicone reaction, that it's like kind of embedded within the wall of the capsule. Like, those capsules should not stay in. Even if they've been in for a while, they shouldn't stay in, even whether or not you're symptomatic.
Yeah. I have to ask this because the ladies of Instagram, they want to know. And if I don't ask, then they'll all be so upset with me. But a lot of women are thinking in terms of, okay, if implants are off the table, maybe there's too much risk there. I'm not willing to go down that road. But I've had some kids, breastfed some babies. Things just don't look the way they used to. What's your experience with women that are doing lifts and that are doing fat transfers? Because I get that question all the time. Like, can I just do a fat transfer? Is there any downside? Is there any risk? Do you see women have negative outcomes in going that route?
That is a great question. That's probably my favorite question today. The answer is yes. And let me explain. There are two separate issues: fat transfer and a breast lift. I have a very low threshold for doing breast lifts on my explant patients. Why? Because I think most people need it. What women don't explain, and this is kind of part of my kind of talk with everybody when they come in as a new consult. A lot of women don't realize you put an implant in, whether it's 200, 300, 400, 700. Obviously, the bigger the implant, the more of a stretch you're going to get. But those implants stretch out your breast tissue and stretch out the skin envelope of the breast tissue 100% of the time. And now, if you have someone who's young and maybe they haven't been pregnant or breastfed, or maybe the implant hasn't been in that long, and their skin integrity is good, they have good elasticity in the skin, they don't have a lot of stretch marks, you might be able to take out that implant and do nothing else, right? Because their breast hasn't really aged and hasn't been put through the ringer, and they don't really have any sagging. And sometimes, in this is true, I practice too. I mean, in a smaller percent of patients, sometimes you can just take the implant out and do nothing else. They don't need fat transfer because they have enough in their own tissue. They don't need a lift because they have enough sag.
Okay.
But overwhelming majority of my patients need and or want a breast lift to help kind of rejuvenate the breast after I take everything out. The overwhelming majority of patients have too much skin. So whereas, and even if they don't necessarily look like they have a lot of sagging with the implant in, as soon as you take that implant out, the volume decreases. And a lot of this has to do with like how much of their own breast tissue they have versus how big is the implant, right? And obviously, and I tell everyone, your result really has a lot to do with how much breast tissue. The more of your own breast tissue you have, the better your breast is going to look when I'm done. Because if I can do a breast lift, great. I mean, I have so many patients who I think they take out their implants, do a breast lift, and their breasts look 10 times better than they did with the implants before surgery. I mean, if you think about it, you're taking, and then when I do a lift, I'm not really breast tissue. I'm really primarily just getting rid of extra skin. So I'm taking a reshaping the breast. I also take that opportunity, and this is probably a conversation for another day, but I'll take that opportunity when I do a breast lift to repair the pec muscle, because most women who have implants have them under the pec muscle. In other words, their surgeon lifted up the muscle and or cut it in order to accommodate this implant. And so, and a lot of those women, you can kind of see that when they we call that animation deformity. If you're standing naked in front of the mirror and you sort of flex the pec muscle, you can kind of see it push the implant aside.
Wow.
So I'll like to take that tissue, that for someone who's breastfed 3 kids, their breast is kind of hanging out their abdomen. Get rid of the extra skin, take that tissue and tack it up to the pec muscle to keep the pec muscle down, keep it from window shading up, and also get that tissue off of the abdomen and into the breast where it belongs. And it sort of auto-augments the breast with your own tissue. I'm taking this much breast tissue and compacting it into a smaller space, which affords me the opportunity to make it look better. And it's obviously a smaller, perkier breast mound. It's usually more proportionate to the chest. And so that's kind of the breast lift portion of it. Fat transfer is great, but totally different, right? So fat transfer is if someone, after I'm done, whether I do a lift or not, after they've healed, if they don't have enough volume and they want more volume, you're basically I do a low pressure liposuction. Patients, the biggest problem is patients who need it the most don't have enough fat. So sometimes you got to really hunt for it. But we'll take what patients will give me, take that fat in the operating room sterilely, process it, and then re-inject it into the breast tissue to add volume. Now, for some patients, they have enough breast tissue, but maybe they have like a little contour deformity or a little indentation as a result of the implant kind of pushing through the tissue over years. Now, sometimes I can fix that with the breast lift, and sometimes you can't. I mean, if there's no tissue there, I can't do it. And I've had patients where same patient, same breast implant, but it's set differently, and I do a lift on one side, and one side's perfect, and the other side they have like a little contour. So for that, fat grafting is great because I can go back and do my what I call post-production 6-12 months later. Come back and sort of break it, scar tissue, and put a little bit of fat in there and try to contour to round out the profile of the breast. Now, there's different philosophies on this. I personally don't like to do it at the same time that I do take out the implant capsule, especially if I'm doing a breast lift. I have done it at the same time. That's why I'm doing just an explant. and capsulectomy. But, and this kind of goes back to our first set of questions, most patients who present with BNI are extraordinarily inflamed, swollen, and have a fair amount of fluid retention. And so the breast tissue likewise is inflamed and swollen. And so I just think that it's not a great time to be fat grafting, because when you fat graft, you're basically taking it from one area, washing away the dead cells, and then re-injecting it and expecting your body to grow new blood vessels into that fat for it to spread. If your body doesn't do that, the fat graft will just kind of melt away and absorb or harden and become low nodules of fat process, which is not fun either. Both are risks of fat grafting. So there's that. And then even if someone does even if I do a breast lift on someone at the same time, then I don't like to fat graft. A, I think the percentage of fat take is much lower. B, it doesn't afford me the opportunity to let everything heal and see where we need that's belonging the most. But the other thing is I think it's a little too risky in terms of potentially harming the blood flow to the nipple and areola when I'm doing a breast lift, right? Because when I'm doing a breast lift, I'm pretty aggressive rearranging the breast tissue, and you're counting instead of the normal, let's say, 6 arteries that go to the nipple. When you're doing a breast lift, you're counting on 2 of those to keep everything alive. And then if you take fat and start, putting under pressure, putting it around that residual artery, you can knock it off. And so I'm not well to do that. So I just tell patients I'd rather do it like 6, 9, 12 months once everything's kind of healed and softened. And some people do great with that. And some people, I'll see them back in 6 months. They're like, I thought I was going to need fat transfer, but I don't need it. So I just save them an operation. So, not everyone needs it. And some just need the tiny. I think they're both great operations. They both can have complications, as we talked about. Specific to fat grafting, the big thing is the graft may not take. So that's not a hurtful thing, but it's kind of, upsetting if you have all your fat melts away. So obviously, fat's hormonally responsive rather, and also will be affected by changes in weight. So if I do fat grafting and so on, and they're like, oh, I decided to get, join the gym and I'm eating healthy now, and then they drop 20 pounds, that fat's just going to melt away. So there are a lot of nuances to it. Apart from that, you got to be careful. You got to have a good radiologist when you're getting your ankles ready, because a good radiologist will be able to tell, like, oh, well, this is the calcification for fat grafting versus this is like a malignant calcification that could indicate cancer. Or this is, this looks like fat necrosis versus, being something more sinister.
Yeah. Ooh, that's so good. Because I've definitely gotten that question so many times. I didn't have a lift or fat transfer or anything, but I was also like very compromised. So for me, it was just like, let's just get them out.
And there's something to be said for that, because if you then are feeling better a year later, you're going to do much better having a lift or having fat, especially fat grafting. I mean, I think most people do well with a lift either way, as long as you do it right. But yeah, I mean, not everyone is going to tolerate that whole operation at one time, or they don't want to, and that's not unreasonable at all. Yeah.
Oh, that's so good.
It is.
I love this. This has been this is a fun little conversation, because I my experience was back in 2019, but there's so many women that are exploring this option, and they're kind of looking at like what's the cost to benefit ratio? Like, you got to really like vet out what you're trying to accomplish, and then what it's going to cost you. Like, is it going to come at the expense of your health? And those are like very real questions, but there are always, people looking for alternatives of, okay, well, if I'm not going to commit to an implant, what does a lift look like? And, does that have the same risk? So.
Well, I've always told patients, if you don't need a breast implant, even back when I was putting them in, if you don't need a breast implant, don't put it in, because there's just so many things that can go wrong. I mean, even when everything goes right, there can be things that go wrong, right? And as a rule, I would always tell patients, if they thought they needed a lift, well, like, how do you feel when you have your bra off? Like, do you have enough breast tissue to fill up your bra? And if you do, you don't need an implant, right? Or fat grafting. But like, they take off the bra and like they're completely sagging down. That's a perfect candidate for a lift. And I do primary lifts all the time. I think it's a great operation. It's like a home run most of the time. So, and so I do a lot in concert with explant, just because I think people need it, and that also makes exposure a little bit easier. But I also do them primarily, and now I'm doing a lot more of primary breast augmentation with fat, just with fat transfer, which works. I mean, you're not going to get the same volume probably that you would get with an implant, but I think as long as the patient understands that and is okay with it, I have no problem.
Yeah.
This is great insight, Doc. I think that when people see that there are some, alternatives, and so if they're thinking about getting a breast implant, that somebody with your expertise can actually guide them and seeing if they do, if they're a candidate for it or not, but using this with the fat cell implantation. So this has been really eye-opening. I'm serious. I have a lot of patients, Doc, that come in and they ask me about these things. Even though I do Chinese medicine stuff, they'll ask me about this. Does it bother you? I'm like, I'm probably not the guy to ask.
So you don't have herbs to make their breasts bigger?
And I'm like, go. We need to listen to the podcast. Just talk to Dr. Kevin. I'm just gonna leave it at that. Okay, just leave it at that. But I mean, it's just really been eye-opening, Doc. I really love your insight, and I like how you explain it, and I love your level balance explanation of this, and we really appreciate it. This has been great.
Yeah, I think if you're listening and you've got questions, definitely check out Dr. Brenner's podcast as well, because I know that there's so many incredible conversations around a lot more than just what we've talked about today. But do your due diligence, with if you have implants and you're like, this is a new conversation, but you're trying to put the puzzle pieces together of your health. Really talk to different surgeons. I went through this myself, kind of interviewing, and you kind of have to find your person. And so I think what you said earlier about really having this questionnaire, and really you said you spend so much time with people. And I think that's one area that often gets overlooked.
Mm-hmm. Yeah. Well, yes. And I like what you just said, know your person. You have to, I think it's just as important that I like my patient and think that I can help them as it is that the patient likes me and thinks that I can help them.
Yeah, that's great. Yeah, it does.
I mean, you have to jive with your surgeon, or you should jive with your surgeon. But if you don't, you're just asking for problems down the road.
Totally.
I agree. I mean, not everyone. I see a ton of new patients every consult, or twice a week. We do full day consult. Not everyone is the right fit for me, and nor am I the right fit for everybody. But I think if I can help someone and they're happy with it, and they like my plan, and I think I can do a good job of it. I mean, any day.
Doc, this has been great. Go ahead, Doc. Go ahead,
yeah.
I'm sorry.
So much respect for what you're doing, and just empowering and acknowledging so many people as they're on their journey, because I think that just having compassion for people as they're trying to figure it out when they're frustrated, but also really trying to explore hey, let me link arms with you, and see if we can get there together. And so I have the utmost respect for your work, and I'm going to for sure be able to send so many people to you, because that's probably one of the number one questions I always get asked is who should I go see? And I mean, these women will fly all over the place to go, have somebody.
They do. It's crazy. Thank you for saying that. That have gone very well. That's very well appreciated and received. But I mean, it's true. I mean, you have to listen to your patients. And I hear so many surgeons who just don't. Mm-hmm. And I don't understand why. Maybe they're just too busy. But I mean, I would not have a practice were it not for my patients. And every surgeon wouldn't have a practice were it not for the patient. So if the patient isn't at the center of everything that you do, there's no point in being a surgeon or a doctor or whatever kind of practitioner you are. Right? I mean, if your patients are where it's at, and so if you're not listening to them, that's like rule number one: is listen to them, figure out what's going on, make a diagnosis, and then make a treatment.
Yeah.
Med 101.
Man, Dr. Brenner's got it. The MD, and he gets the big picture of all of it. That's not the case for so many people.
Not so many, yes, Doc. I mean, it's good.
No names. I'm not like
we won't go scorched earth or anything. We're not gonna just, But
not all doctors are bad. There's lots of great doctors.
You're representing the small minority, and you do it so well. So I'm going to champion that for you.
Thank you. And I have lots of referrals to other specialists who are also great if anyone ever needs.
So good. Well, where can people find you? Give us the rundown of all the places that you are so that people can get more educated on you, your practice, where they can find some of your resources. We'd love to share all of that.
So, okay. So first of all, I'm in Los Angeles. My office is in Beverly Hills. We do see patients from all over the country and all over the world. So I don't want you to feel like if you're in somewhere where you don't think there's a plastic surgeon near you, give us a call. I do, virtual consults initially just to kind of feel things out for patients to see, do I think I can help them point them in the right direction? So just because you do a virtual consult doesn't mean you have to plan your surgery, although we do that all the time. So if you're out of state, my office is adept at coordinating that for patients. In terms of how to reach me, the best thing, I always tell everybody, the best thing is to just call me on the phone, not me specifically, not my cell phone, but the office line, which is 310-777-5400. You can always get a hold of someone, leave a message, and my staff will get back to you. That's the best thing. I'm also obviously online at kevinbrennermd.com. My Instagram, I do have lots of people kind of helping me with Instagram, but we try to get to every question and inquiry and whatnot. It's not the most expedient way of getting into my office because I just don't check it that often, but I do get back to people eventually on Instagram, and that's at KevinBrennerMD. So you can DM me on Instagram. But probably the best thing is either go to my website and fill out a contact form there, or just call the office and we can help you from there.
That's been great, Doc. Well, we really appreciate you having you on here. We really appreciate you coming on and informing us all. And we encourage everybody, if you have any questions, get in contact with Dr. Kevin and check out his website, check out his Instagram feed. And from all of us here at the Institute, Doc, we really thank you. And for everybody out there, just please, if you have anybody with any questions about this, listen to this podcast and refer to Dr. Kevin. Thanks, Doc.
Thanks so much. Keep putting the word out there.